to those of you joining us from the East Coast, and thank you all for standing by. I'd like to welcome you to our webinar, The Risk Adjustment Treadmill, Keeping Pace in an Ever-Changing Market. My name is Sean Forster, and I will be the moderator for today's discussion. But first, a little bit of housekeeping. During the presentation, all participants will be in a listen-only mode. We do, however, encourage you to ask questions throughout the presentation. To do so, please submit your questions using the questions window located on the right side of your screen in the GoToWebinar panel. It should look similar to what's shown on the screen here. Type your question into the box, click send, and they will be sent directly to a meeting organizer for use during the Q&A session we will host at the end of the hour. Should you encounter any technical difficulties, please also utilize the questions window to describe your issue, and one of our support staff will follow up with you to troubleshoot. I will say, though, from experience that in most cases, technical difficulties are a result of poor connections and can usually be resolved by exiting and rejoining the webinar. By the end of the hour, our goal is to have you get a better understanding of the trends impacting Medicare Advantage risk adjustment programs and take away a handful of best practices to your organizations that you can employ. More specifically, we'll discuss the bullet points listed here. With that, we invite you to sit back, relax, and enjoy today's presentation. Our featured speaker today is Pam Klugman. Pam brings more than 25 years of experience in healthcare and Medicare. Prior to joining the CO team, Pam was co-founder and chief products officer of ClearVision Information Systems. Before that, Pam served as manager of IT, Medicare Revenue Improvement and Recovery for Blue Shield of California. She also held roles as senior Medicare auditor for Blue Cross of California, reimbursement specialist for Cedars-Sinai Medical Center, and finance coordinator for Northridge Hospital. Throughout her career, Pam has worked on many system development and data analysis projects, including the optimization of tracking and reporting encounter and claims data using compiling submissions under the CMS risk adjustment model. Experienced in contract utilization data, HIPAA compliance, and risk settlements, Pam has been active in the Industry Collaborative Effort, or ICE, since its inception in 1998, and has co-chaired the ICE Risk Adjustment Data Acquisition and Reporting, or RADAR, team for several years. Our presentation today consists of 4 sections. First, we're going to talk through some of the key changes that were announced in April's call letter. Next, we'll cover how payers and providers can collaborate to better achieve a common goal. We'll also talk through some of the tactics that can be employed to keep on the risk adjustment treadmill. And we'll close the content portion with a word on the importance of program measurement. Throughout the webinar, we're also going to be asking a series of polling questions to help understand your perspective on these topics. And again, the webinar will conclude with us using our remaining time for the Q&A session. So remember to submit your questions throughout. With that, time for me to step aside, and I'll hand things over to our speaker. Pam?
Thank you, Sean, and welcome everyone. And East Coast to West Coast, good morning, good afternoon, or good evening. We're going to talk quickly about the revised payment model. So on the screen you see some information about what the updated model includes, but first of all, let me say that the determination of which segment of the population a member falls into has not changed. But what has changed? The community model will have 6 separate segmentations, and on the screen you'll see those segmentations as well as the proportion of the population that is expected to fall into each. The dual status in any payment month will determine which segment a member falls into. And CMS issued a memo on 6/10, which is out for comment by 7/29 on their proposal as how to operationalize this. So if you haven't seen that proposal, take a look, and if you have comments, please make sure they're into CMS before 7/29. So there's 2 additional segments, and they are the LTI and new enrollee. LTI will include the Medicaid factor based on the status in the payment year, not the payment month as in the community segment. Therefore, there will be no separate Medicaid add-on for LTI or community, as they're going to be included in the segment depending on their full or partial dual eligibility. The years for calibrating the model have changed from 2010-2011 to 2013-14. And of note is that the LTI costs from SNF, home health and DME has decreased between those 2 years. So the newly calibrated models, they'll be used for MA plans, including the MMPs, the Medicare, Medicaid plans. Each segment has relative factors that are independently developed for that segment, and they're going to reflect a specific relative cost for an HCC in that subgroup. So all across those 6 models, the weights will be different depending on what segmentation the member falls into. Disease interactions have been updated. However, the PACE model is unchanged, and you can find information on the PACE model in the 2011 announcement, and it is still using data calibrated on the 2006-2007 years.
Great, thank you, Pam. That brings us actually to our first polling question of the day. So if our team could please launch the poll for the audience. And Pam, you just went through 6 of the changes that we feel really have impact on RAF scores going forward and will need to be addressed in order for organizations to stay successful. So our questions to the group is this: what changes to the CMS HCC risk adjustment model are or will be the most challenging to incorporate into your program? Is it A, increased granularity of the community model segment, B, updated disease interactions, C, transition to EDPS data, D, monthly monitoring of dual eligibles, or E, other? So we'll give everyone just a few moments to input their answers there. All right, why don't we go ahead and close the poll. And it's looking like we have sort of 2 front runners here. 35% believe the increased granularity of the community model segment, and another 33% in second place there think that the transition to EDPS. So I don't know, Pam, if that's what you would expect to see as sort of the two biggest challenges?
I agree. I think those are 2 very big ones, and also monitoring the dual eligibility and how that's going to be done on a month-to-month basis, which I think goes hand in hand with the increased granularity because one affects the other.
Yeah. Okay. Great. Why don't we close out the poll and continue with our presentation? Thank you, everyone, for participating in that.
So let's move forward to what else is changing. Encounter data as a diagnosis source. We're moving toward a higher blend of EDPS to RAPS, and CMS proposes a complete transition to RAPS by 2020. Don't know how many of you have been doing this for how long, but if anybody can name one instance where they've been on time with their predictions, that would be interesting to hear. So for EDPS, the final 2015, based on 2014 dates of service, actually took place this month. 2015 was supposed to be additive of EDPS and RAPS, no blending, total additive. Now, the July marks or payment notice also came out the end of June, and CMS stated there would be another 2015 final settlement in early 17. However, there's been no mention of why or what this will incorporate. General consensus, however, seems to be that they may be adding the EDPS portion at that time, but there's nothing official. Again, no word on why there's a second settlement, and this will be the first time that's ever happened. For payment year 2016, the blend will be 90-10. That is the current year that we're in. And again, the EDPS will be incorporated in the final settlement. So after the 2017 sweep, January 2017. During this entire year, we're being paid on what's been submitted through the RAPS process. Moving forward, there's a greater emphasis on EDPS, with 2017 blend being 75-25 RAPS EDPS. But another change is that they will incorporate this into the mid-year true-up for 2017. We'll wait and see if that actually happens, since it appears that they haven't done the final with the added EDPS at this point. So the questions often arise, why are we moving more toward encounter data? Well, there's an increased industry focus on encounter data because of need for healthcare payments to reflect the population illness burden. Also, quality ratings such as HEDIS and STARS are in part based on the clinical quality metrics calculated from encounter data. From the political spectrum, we have legislators and policymakers that are pushing toward healthcare cost and quality transparency, and also a move toward value-based purchasing in all lines of business lends itself to encounter data more than a RAPS, which is a 5 or 6 data element subset of the claim itself. Now, CMS can also get information on physician practice pattern analysis, which hasn't been talked about this go around with encounter data, but it was a big subject in the early 2000s when they tried to enforce use of encounter data. There was a lot of physician pushback, and that's why the first foray into using 837s for risk adjustment didn't go over quite so well. And also, let's not forget the increased cost that CMS has to bear by running 2 parallel systems, RAPS and EDPS. So general thought is that to go to one system as quickly as possible will decrease the cost CMS has to bear. Here's a snapshot of the changing timeline for incorporation of EDPS and the phase out of RAPS by 2020. You can see payment year 16, it's 10% going to 25, 50, 75, and 100. So we'll see the risk in itself going from cost to risk with a longer timeline than first proposed. We'll see what happens with this EDPS timeline. So what processes need to change in order to support this model? You have to understand CMS filtering logic, and while it's very similar to health plan logic, and you can probably predict that no 2 health plans are filtering exactly the same, but even if the health plan logic was identical to that of CMS, the risk adjustable code output would vary from the health plans because of the requirement for plans to use physician specialty as a filter, and CMS is not using physician specialty as a filter. It's important for both plans and providers to identify variances in this filtered risk adjustable code, as well as gain insight into the payment difference that may result. You have to validate that all diagnosis codes sent to the plan, the providers have to validate all diagnosis codes sent to the plan, whether on a claim, payable claim, an encounter, or the alternate submission method, also called the ASM, made its way to the plan and from the plan to CMS, both in a RAPS file where the health plan did the filtering, and its entirety on the encountered side where CMS is doing the filtering. The health plans, as well as the groups, and this is why the health plan should share information with the groups, should ensure that rejects from both RAPS and encounters are corrected and resubmitted. And one point that we've seen overlooked quite a bit, if there's a RAPS delete, you also need to delete it on the EDPS side. This is especially true for payment year 15 because it's additive. So if you deleted a lot of RAPS from your 14 days of service and you neglected to delete it on the EDPS side, you're still going to have that overpayment. Another important thing to note is that both plans and providers should spend adequate time and resources to familiarize their risk adjustable teams, as well as all their teams, with a revised model and an understanding of the impact of the 2 different data sources, especially since we are moving away from RAPS, which is a very minimum amount of information, to a full 837, ANSI 837, also called encounter data.
Great, thank you, Pam. And that brings us to our next polling question of actually a set of 2 questions for our audience. So if we go ahead and launch the first one, please. And we know that we have different organizations are at different stages of adapting to or refreshing their risk adjustment programs to incorporate the new blended data sources. So our question to the group is, how far along would you say your organization is in implementing changes needed to support the RAPS EDPS blended data source? Are you all done and ready for the next blend change? About 75% of the way there. Maybe you're about halfway through the changes you need to make. Have a plan in place, perhaps, ready to begin that project. Or have you not started yet and hoping that CMS will change their mind here? Hopefully we don't have too many in that bucket, but wanted to make sure we had all our bases covered. So if you go ahead and leave the poll open just a little bit longer, it looks like around 40% or so have submitted a vote. So we'll get that around the 60% mark. All right, why don't we go ahead and close, and if we could share the results, please, of this first question. And it looks like, Pam, we have 50% of folks that are in the have a plan and are ready to begin the project, and just 3% are ready for the next change. Does that surprise you? Most people are in the planning stage without yet put it into practice.
Yes, that's very surprising, actually. Many of the clients that we're working with have started last year, and are well into having alignment between EDPS and RAP submissions.
Okay, so that's a little bit of catch-up, maybe, from the group we have here. So I'm going to go ahead to our next poll question here. So, another thing, we know that we have both providers and health plans joining us on today's call. So this next one, answer it from your own perspective. And we promise that other attendees, no one can see your responses here. So if one of your partners is on the call, they won't see this. But our question is the data shared by either your payer, if you're a provider group, or your provider, if you're a health plan, adequate to run your risk adjustment program? Just three simple options here, either yes, no, or not sure. So I'm really curious to see how this one pans out. Looks like we have about 30%, get up to 40% voted. So we'll give people just a few moments to answer the question here. Why don't we go ahead and close the poll and share the results? A bit of a mixed bag. Looks like 34% yes, that the data share is adequate. The majority, though, 44%, are in that no bucket, and then an additional 20% is not sure, which is okay. We have a whole section coming up next on collaboration. Hopefully we can glean some things to move the folks that are in that 40% to join their peers in the 34% of yes.
So let's do a little bit about what have we learned to date. So getting consistency and alignment between RAPs and EDPS is not a straightforward or easy process. Although some plans are changing their logic to coincide with the CMS filtering logic, there's still that exception of physician specialty code, which is pertinent on the health plan side, and CMS is not using it on their side. Proactive plans are investing a tremendous amount of resources to clean up their claims, processing, and data flow. And we have worked with clients who have seen as little as 10 to 15% variance and as much as 40% between the two data sources. Now, most plans and payers are struggling a lot with the EDPS side, as the data can be messier. There's more issues with member numbers not matching, etc. So it's not for a lack of trying. Again, the disparity in the filtering logic, the need to get data through the front door at CMS before it can even be considered for risk adjustment is an issue. And to add sort of insult to injury here, or salt in the wound, if you will, at the spring conference, CMS did announce that they are aware of problems with the MAO 004, which to all of us is analogous to a RAPS return file. In other words, once the 837 has made it through the front door at CMS, then it's made it through the filtering logic, and those diagnoses are set to be accepted for risk adjustment. The return file giving you that information is incorrect. We know that the suffix is often wrong, and CMS has said they will reissue all MAO 004s, but there is no ETA on that yet. So while they're trying to work at that, we all need to clean up our data flow, because CMS is continuing to weight EDPS information higher and higher in terms of its percent of the data source from which our risk adjustable weights will be set. So the degradation, again, we frequently see degradation in EDPS scores as opposed to RAP scores, not because there's less risk-adjustable codes using CMS filtering logic, but due to the added complexity. So often, all the diagnosis codes are not getting to CMS as a result of EDPS rejects. And those are typically front door rejects. So they don't get in the front door. And some people may be seeing less EDPS risk weights because of the inability to match the MAO004 back to the RAPs, back to the member, because of the inconsistencies in correct suffixes on the HIC numbers. So now we know about a lot of problems that are out there. Let's talk about data sharing for collaboration. So the saying goes, it's an ill wind that blows no good. So something that's bad on one side is likely good on another side. So what's wrong for you is right for me, or what's right for me is wrong for you, or however you want to do that. So the silver lining in the CMS data source change is it's forcing the industry to resolve one of the key frustrations that have always been between payers and providers, which is reconciling conditions assessed and services provided with what CMS believes to be true based on the health plan submissions. So on more than one occasion, we have encountered provider groups with clinical data in their claims database that is not on the RAPS return files. How can this happen? Well, there's a variety of reasons it can happen. I think everybody on the phone probably knows one or more. But when the plan and providers are looking at the same data, i.e. the claim was submitted, yet the filtering logic prevented it from flowing to CMS, there's a collaborative understanding of the cause, and nobody is pointing the fingers at anybody else. So here's an example of a scenario that we see played out time after time. The provider is sure, I mean, they're the ones that saw the member. They're sure they saw the member, but the specific data never made it to CMS. They know this. How do they know this? Because there's a feedback loop, which is something that we also provide, a feedback loop to the providers of what made it to CMS. If taking a deeper dive into the data and working with a health plan showed that there was an interface issue between the plan and the provider. Nobody knew that at all. Nobody knew it because nobody had shared previously the CMS view of reality with the providers. So you have to think about the fact that both sides benefit from working from the same page in the playbook and aligning their systems to achieve the proper reimbursement. It's to everyone's advantage to work together. Some actions that can be taken to help facilitate a constructive dialogue between plans and providers is to facilitate a collaborative approach to data sharing and aligning it, which is important to all the parties, that they have access. Both parties have access to the one record of truth, for lack of a better term, and mainly it means CMS's reality at any given time. When you think about it, the provider community are the ones working with the members. They know who they've seen and they know what conditions they've seen them for. They're the ones that can determine if the data CMS has in it is in fact complete and accurate. Once they have this view of the data, it's a powerful tool that can be utilized to dialogue with the plans and find ways to achieve parity between what CMS has in hand and what services the provider has performed. One of the tactics to do that would be to share the average risk score by provider. It's a good place to start. Does the risk score that CMS has calculated or you, the plan, have calculated based on what you have in your hand reflect the same level of acuity that the provider feels is true for that member, for the services that they have provided? As an industry, we have 6 months to improve our processes before the 25% EDPS weighting. So the 2016 dates of service in CMS's hands by March of 17. That is going to determine the mid-year, and it's going to be 75% RAPs and 25% EDPS. So how many of us truly can afford for 25% of our payment to go away because the EDPS portion is inadequate? I don't think any of us can. So it's really, really important to get that alignment and to get it as quickly as possible. And again, if you're working together and you see a discrepancy, collaborate on why it is the way it is. You know, nobody is waking up in the morning and saying, let me see how I can pay the providers less. Or there's no provider getting up and saying, oh, let me see how much data I can withhold from the health plan so I don't get paid right. Everybody wants to do it right. So as soon as we can all get together and look at this as a joint effort, not one or the other, but a joint effort, and collaborate toward getting the most robust and accurate data to CMS, we'll all benefit. So it's also important to understand your data flow. And sometimes some of the most important things that come out of data sharing is, as we said earlier, identification of missing data. I mean, literally, we have found $7 million in 3 hours by sharing CMS's reality with a provider group and them knowing that's not true. So $7 million, 3 hours, and it's all about collaboration. So we're all too familiar with the fact that we operate in an extremely fragmented care delivery system. So it's important to understand your data flow so that you know you're sharing a full data set. We can't emphasize this enough. And I know one of the things we have always emphasized is understanding your data flow. And people will look at this and go, oh, that's old news. We know that. Well, yeah, maybe old news, but I don't know of any house that is built on a shaky foundation that stands up for very long. And they've been building foundations for houses for hundreds of years. So we're attempting to build and increase the stability of the foundation of our data. So it's like playing telephone. It's important to understand every change of hands that your data goes through. And when you play telephone, when you were young, I don't know how many of you played that, or if I'm actually dating myself here, but in this case, you don't want the funny story about what the message ended up like at the end. You want the end message to exactly replicate the first message. So it's important to know how many hands it goes through, your data goes through. Do you use a vendor? How are your claims people doing this? So that brings us to sort of like the honeycomb of data. You know, the bees bring it all back and make a nice honeycomb. Well, hopefully you bring it all back and forward and make a nice honeycomb. So the claims diagnosis limitations, make sure there's no limitations to the number of diagnoses that you, the providers, are sending to the plans, and that you, the plans, are storing from them. Send everything you have, code everything, document everything, and make sure your inpatient, outpatient, and physician data feeds are complete. I can't tell you how many times I've done a data flow analysis, be it a health plan or a provider group, and claims department has a totally different understanding of what the systems department has, of what the risk adjustment department has. Everyone thinks a certain department's doing something one way or another, and it's not. At the end of the day, CMS sort of grades health plan claims departments on how fast and accurate they pay a claim. They never score them on how accurately or robustly, if you will, they capture the diagnosis that feeds the risk adjustment side of the house. So there's like a diametrically opposed feature there, where they're being measured on speed and accuracy of dollars, but not on robustness of clinical data. So it's always good to make sure those systems are in alignment. Again, claims entry protocols that make sure they're entering all diagnoses, not just those needed to pay a claim. Encounter entry, make sure your claims department enters encounters as well as payables. And not so much anymore, but we used to find drawers of encounter data at health plans. You know, again, not so much anymore, and this was all before encounter data started feeding risk scores. So it was before risk adjustment days, which many of you may not be aware of. EDI vendor oversight. Really, really, really important here. A lot of times, providers will send data via an EDI vendor to a plan. Who's working those rejects? Who is reconciling those numbers? You may send 1,000 claims and encounters to the vendor. Now, granted, you're likely to have greater oversight on your payable claims, but what about the encounters? Say you send 1,000 encounters and they reject 200, 800 made it to the plan. Who knows about those 200? Who's fixing those 200, tracking those 200? And of the 800 that made it through, maybe the plan rejected another 200. So you sent 1,000 and 600 got to the plan. Oh, then the plan rejects, sends some to CMS, and then they reject them. So you've done work on 1,000 members. Maybe 500 made it all the way to CMS. Unless you know that, you're never going to be able to reconcile payment with resource consumption. And by resource consumption, I mean the work you, the providers, have done with the members. Feedback, again, feedback reporting at every step of the way. So if you sent 1,000 and 500 made it to CMS, you need to know what happened to the other 500, and whoever is the appropriate person or department should be taking care of monitoring those rejects and reprocessing and resubmitting as necessary. Another place we find could use some help is what we call, it's basically claims volume, but a volume both in terms of quantity and quality. So maybe you're getting the appropriate, 9 to 12 visits with a physician per member per year, but every single one of them has 1 or 2 diagnoses. You're getting good quantity, you're getting bad quality. So not only the number of claims and encounters you get is relevant, it's also the robustness of the data inside those claims and encounters. Okay, so let's talk about the actual tactics of getting this done. There's retrospective and prospective, and also concurrent as well. So often we talk about the need for, we call bifocal vision. So it's a balance of retrospective and prospective work for a successful risk adjustment program. Oftentimes, and maybe too often, we see plans and providers putting all their resources into retrospective. This can be costly and doesn't have the same impact as taking care of business, if you will, at the time the patient is in the physician's office. While you need both, you're always going to need retrospective and prospective. The trick is to find the right balance. We have no control over the past, but we can impact the future. What I mean by that is when you go do a chart review, cross your fingers. All you can do is cross your fingers and hope that what you're looking for is documented. But the flip side is, if you see something that was submitted that's not documented, there's an obligation to delete this. It has to be two-sided. You can't just go in digging for dollars, if you will, digging for diagnosis. You also have to go in, look at that chart, make sure that the coding is accurate for the data submitted, see if there's any coding for data that wasn't submitted, and then remove things that have been sent that aren't substantiated. But you can't change that. You can't change what is in there. So there's a lot of tactics people use for risk adjustment and quality measure improvement. Suspecting list, both proactive and retrospective. Prospective forecasting, chart reviews. What do you think is the most effective use of resources? Prospective or retrospective? A lot of it is just based on your experience, where you are in your organization. What we feel here is that an effective program has both. You leverage both retrospective and prospective. The trick, again, how much resource do you invest in each? Our philosophy here leans toward primary focus being prospective tactics. Supporting the patient-provider interaction ensures not only a continuity of revenue, but a continuity of care. And more importantly in that statement is the continuity of care. If a provider has a complete view of previously diagnosed conditions and data on suspect conditions, they can manage the oversight, documentation, and treatment of those while the patient is in the office. So I don't know how many times my mom has come home and said, oh, they want me to come back for this and they want me to come back for that. So she doesn't like the fact that she has to go back and forth because, first of all, it's a lot of trouble for an elderly person to get it to the doctor. And secondly, every time they go, there's a co-payment. So an effective program would be beneficial not only to the provider but to the member. Supplying information to the provider prior to that member walking in the office. It has to include not just claims information, but also the CMS view of that information. In other words, here's everything I've diagnosed for you, both risk adjustable and not. Here's the risk adjustable that have made it through to CMS, because there can be information there that came from a different source than your provider site. So you have to make it easy for the provider to combine, to know what risk adjustment deficiencies are out there. You have to make it easy for them to also know at the same time what quality gaps are out there. So you can combine both, integrate risk and quality together. And again, it will alleviate you having to call a member back, which annoys them to no end. I can tell you because I hear about it. So, so certainly retrospective efforts are needed, certain quality measures as well as auditing purposes, but in general, the more discipline and focus you have on the prospective side, the less energy you'll have to invest on the retrospective side, energy in human and financial resources. If you work toward efficiency on the retrospective side and you share your criteria for chart reviews with the providers and see if providers are already doing their own internal chart reviews, perhaps there's an opportunity to leverage some of their processes and findings. So, and if you're a plan and you're doing chart reviews, make sure to share the findings with the providers, which will allow them to improve their processes. So don't just go back and look for things. Whatever you find, good and bad, share that with the providers, because it'll help them improve their processes and hopefully move all of us away from such a reliance on retrospective work. So I briefly mentioned how nice it would be to have quality and risk together in the hands of the physician when the member is in front of them. Because if you work to improve your risk scores, your quality scores go up as a byproduct. When you do them both together, you can have an even greater impact on the quality of care and the revenue you generate. I was working at a health plan, working on improving risk adjustment scores, outreaching to providers, outreaching to members, not even aware, quite honestly, and this is more than 10 years ago, but not even thinking about the impact on the HEDIS side. When the HEDIS scores were calculated based on that data that we had collected, the auditors couldn't believe how high the scores went and asked us what we did. And we showed them that, you know, we just got an abundance of data for risk, but that abundance of data spilled over and tremendously improved the HEDIS scores. So some background information, I think we're all aware of this, that CMS calculates a risk score for each enrollee each year. And that score reflects a prediction of the beneficiary's likely costs based on their demographics and their health characteristics. The risk score determines the revenue for a health plan and often the contracted providers, and this payment is received monthly. So an accurate risk score can have significant impact on revenue, particularly for people with many chronic conditions, often increasing revenue by 2 to 3 times. From a care perspective, in order to ensure a continuity of care, it's important for a provider to have an accurate view of all health conditions a member has. On the quality side, health plans and providers are incentivized to continuously improve the quality of care provided to the members, and many programs include a bonus payment based on quality scores, and it can be up as high as 5% of the monthly revenue. So from a care perspective, HEDIS stars and P4P provide an objective way to evaluate health plan and provider performance. Again, doing these together, beneficial to the provider, to the member, and the plan in terms of care and revenue. If you can keep a member healthy, say you have a member that has 3 chronic conditions, and you proactively treat those conditions, you keep him healthy, him or her healthy, you document the conditions and you send them in, and you get paid for that higher level of acuity, the delta between your expenditures on treating them and the money you get and get to keep for other benefit programs as a result of the fact that they're not using those extreme healthcare resources because you're keeping them healthy, everybody wins. Quality of life improves, not only for the member, but for the group and the plan, because that delta in the dollars you can use to increase your benefits.
So our last section of content, I believe, is on the measuring results. And before we get to that, we actually have our fourth and final poll question. So if we could please launch that and get the one last input from our audience here. And that is, just before we get into it, how do you currently measure the results of your risk adjustment programs? We've got 5 options for you to consider here. Manually pulling reports or spreadsheets. Perhaps you've automated that process into monthly reports. Some folks may use a software solution. Again, hope this isn't too many folks, but maybe we're not measuring outcomes at this time, or there may be another option that's not listed here. So we'll give folks just a few moments to submit their responses. Looks like about 40% have voted so far. You know, it's around that 50–60% threshold. So why don't we go ahead and close the results, please, and share for the audience to consider. Okay, so we have actually sort of a nice even distribution here, starting with the majority of people, 37% manually pulling reports and spreadsheets, 28%, about 10% less, automating monthly reports, 18% are using a software solution, just 6% don't measure, so I think that's a good sign, and 9% are using the other. So it sounds like it's mostly a manual process at this moment, but some other folks a little bit further along. Is that consistent with sort of usage from?
I would have thought more people would use a software solution or automated, but hey, as long as you're getting results and measuring results, that's the important part.
Okay.
Okay, so again, we believe that measuring your results is an indicator of a well-run adjustment program. So I'm sure all of you have come to a point where the COO or the CFO invariably asks, how effective is our program? What's our ROI? What kind of results are we seeing? So again, an important part of a well-run risk adjustment program is measuring results. One way to do this is set a year-end goal, but break it into smaller measurable chunks, quarterly perhaps. A large year-end goal can seem overwhelming, but incrementally measuring that and setting goals at a much more often time frame, you can achieve them. The first audit I ever did, I used to be a Medicare audit, the first audit I ever did was a hospital. It was a home office with 2 hospitals and a couple home health agencies. We brought 9 stacks, 4 feet high, of audit work papers, and the auditor that was training me said, don't look at that. If you look at that, you'll like have a heart attack. It'll just be overwhelming. He said, grab one stack, grab one section, start on page 1. And it took 9 months, but we worked through that audit. So again, when you measure goals, set interim goals that are achievable. Some examples can include a % of change in overall risk score. You can target lower performing providers. And when I say lower performing, while they may have a low RAF score, their acuity level of their members may be high. So low performing doesn't mean they're doing their jobs incorrectly or not well. It means something's happening to the data that they're accumulating. So you can set a target % of members receiving an annual assessment from a given provider, but again, go back to the beginning, go back to the foundation. How does that data move? Because you can have some really, you can have some providers with some very, very, very big panels of members, and they see a lot of them every day, but for whatever reason, that data that he's accumulating doesn't make it all the way to you, the plan, and then to CMS. Create a balanced scorecard. So your risk adjustment dashboard should reflect many aspects of the program, your RAF results, initiative return, on investment, provider engagement and satisfaction reporting, as well as audit results. And it should cover your retrospective and prospective tactics. Dashboard should always be easy to interpret. A lot of people use that red, yellow, green indicators now. You can watch monthly results and trends over time. So important trends might include the quarterly RAF score and RAF trend by provider, group, PCP, or geography, year-over-year adjustments, and program costs. Trending over time can help identify data seasonality and establish a normal variance. So be sure to note the impact of initiatives on year-over-year trends. For example, perhaps a significant bump in risk scores due to a successful inpatient data pursuit effort. That should be documented to support the program learning. So if you're doing an inpatient data pursuit, it's likely because you're not capturing everything or even receiving everything from your inpatient hospital stays. So those kinds of projects are good to do. You can measure return on investment, so be sure to note the impact of initiatives on a year-over-year. Perhaps you do an outreach or you do a data flow on a certain number of your providers, and there's an ROI because you did some sort of a data flow analysis and found inadequacies there. Also, make sure that you celebrate successes. It takes a village. A successful risk adjustment program does take a village, so it's important to recognize key contributors to the initiative. And I'm sure everybody's aware that that's not always just the physician. There's office staff, there's coders, there's administration, there's support getting those members in, doing the outreach to them. Recognize providers that have demonstrated a most significant improvement in care gap closures. Care gap closure doesn't mean that they're going out and providing more care. Care gap closures could be people that recognize the care they're giving isn't moving along the data stream. So again, we're not targeting people and activities they do. We're also targeting accumulation of data that is not moving from one point to another along that whole data stream. And it's really interesting. If you treat a measurement like an advertising campaign, in other words, you communicate it a lot, you talk about the progress, it's really important for ongoing engagement. Look for opportunities to share results in all team meetings, provider newsletters, management meetings, and during strategy review sessions. It's unbelievable if you bring everyone on board, how much everyone gets on board. And it can be a very collaborative and very team-building kind of mission to have everyone involved in accumulating and understanding the data that drives revenue for so many of us. So of the CO Health Analytics point of view, what we've found over time is that small, and I mean small, improvements can carry significant revenue implications. So let's just say at the beginning of the year and a health plan or provider wants to create a suspect list of all the patients they need to see this year. Or if you're doing retrospective, what's missing from last year? I mean, in many cases, you have someone who you're being paid for this year. Excuse me, you're not being paid for this year because you didn't see anybody with that last year, but you already saw them this year for next year. So they're missing a year in between. So you know they have the condition. Those are some really good ways to take a look at who do I need to do a chart review on. So to begin in the year, make sure your gaps are closed and the revenue stream stays constant by looking at who did I miss last year and who do I need to see this year, and collaborate with your providers. So a coder is preparing a member-specific pre-populated form to give to the physician so that they're aware of the conditions previously diagnosed, as well as any outstanding STARS and HEDIS measure assessments they need for that member. These are the kind of things that you can do to make things move forward. Other use cases are quality managers preparing their annual plan for your HEDIS score improvement, and you want to understand how they're performing against each of the measures, or a financial analyst wants to calculate ROI. These are all things that you can do if you have the information on your membership and small improvements. The medical director wants to review an individual PCP performance to determine which are their highest performing providers in terms of their risk scores and which are showing degradation in score. Again, it's not necessarily degradation in work product, it's degradation in data flow. So these small little improvements, we saw a 0.03% increase in the RAF score. It created a $12 million, almost $13 million windfall to the plan at $24 per member per month increase, and at a 35% premium of $4.5 million went to the provider. So again, small changes make big difference. One of the things that we recommend here and that we provide is what we call a HAT form, and it's called a health assessment tool. This gives you, it's one of the many provider collaboration tools that are embedded within the CO RevMax Pro application, and it gives you not only information on the member, it gives you the code, HCC code, the diagnosis codes, and their description, and the last years of service that they were seen. So you're able to take a look at what do you need to do this year and assess whether this condition still exists or not for that member. And on the bottom part is your HEDIS measures and members that fall into a denominator that are numerator negative. In other words, they need to have this assessment done, and all of the measures are NCQA certified. So it's just an example of ways to arm the provider with tools that make him or her efficiently use their time, but also again saves the member from having to come back for gap closures that they, the member, feel should have been addressed on the initial visit. So with that, I'm going to turn it back to Sean and thank everyone for their participation, especially in the survey questions.
Wonderful. Thank you so much, Pam, for walking us through the changes that came from the CMS call letter, talking around the payer-provider collaboration, the retrospective and prospective strategies, and also the measuring progress. I think both are all four really important topics to understand. So exactly right. We're entering now our Q&A portion of the webinar. So invite folks to please submit your questions using the GoToWebinar panel on the right side of your screen. When we're doing the registration, we also asked if folks had any questions. I'll start with those while people are entering in their submissions. So one question we had, Pam, that I'll throw to you is what are the health plans, and this comes from Kimberly, what are the health plans doing to ensure that they are being paid accurately? How are they testing EDPS payment?
Well, that's a very good question. I think right now we can just speculate about EDPS payment because no one's seen payment as a result of that. The 15 payment year was supposed to be additive for EDPS, and that final settlement came this month in July. But along with that, as we stated earlier, is the HPMS memo from CMS that said there will be another final, so final, sometime early 17. I think at that point we can only calculate what we expect it to be, where we may have had an EDPS submission or an MAO4 acknowledgement from CMS for a RAPS diagnosis that triggered a new HCC that we didn't have previously.
Okay, and we actually are getting a number of questions here, and actually this is somewhat rare, but I'll be able to address these. Give you some questions on the slide deck being distributed. I should have mentioned during the housekeeping, we have recorded the presentation today, and we will be making that presentation available as a follow-up email. You guys will receive a link to the recording, so one that I can contribute on. So another question here is when a patient is admitted to hospice, do their claims and HCC conditions still count towards their risk adjustment factor score?
Unfortunately, once a member has elected hospice and their status has been changed to hospice, they're no longer subject to risk adjustment.
Okay. Good to know. Question here around any examples that you can provide. Not sure if maybe the asker can clarify a little bit on what examples. But let's say around collaboration. Have you seen good collaboration between providers and health plans? Maybe if we have while they're submitting in their clarification.
Absolutely.
Yeah.
We've seen when health plans make it easy for the providers, and I know a lot of health plans share data with providers, but they submit it their way, they send it their way, and providers often have multiple contracts. So it's hard for them to understand that data, but if you meet, like for instance, the example I gave of the $7 million, that is a health plan that sponsored an application, actually our application for their provider groups, and they collaborate, they meet on it, they discuss it, they share reporting. If there's a discrepancy, they talk about it and they resolve it. Nobody's blaming anybody. They're looking to resolve an issue so they can make sure it doesn't repeat, because both parties suffer when the right information doesn't get to CMS, and we've seen it time and again. We saw less than 90 days, $10 million when a 3,000 member provider group up in Northern California was able to see what did that CMS actually have. And they found $10 million worth of claims sitting in their system, the provider system, that hadn't made it to CMS for a variety of reasons. And at that point, it doesn't matter what the reason is, make sure it gets in. It was $10 million to the plan and whatever the provider's percent was, because they found data on resources that had been consumed that CMS didn't know about. So it is alive and well out there, and it would be really good for the industry as a whole to embrace true collaboration and share beginning to end with providers, and everyone would benefit.
So a lot of good questions here around collaboration and specific to actually the HAT report you mentioned. If you're a health plan, how exactly did the provider access that? Is something that's shared? Do both people have to be on the same system, or maybe?
It depends on the relationship. It depends on the relationship. Some health plans send PDFs of this information to the providers. Some health plans, I mean, both can get access to the same system, so they're all looking at the same data, updated monthly, all at the same time with all the information that's out there. And I think that's probably the best way for this to happen, is for both parties to be on the same system, and a provider can have all their health plans in one system, and the health plan can see all their providers in their system. So that's true collaboration to me. And so that HAT is just one example of ways to take this data and share it across the board. So yes, to your question, and it can be provided by the plan, it can be delivered to the group, and it's all web-based online.
So let's see, I have time for a handful of questions. We're already enough flood time. I'm afraid some of these we'll have to follow up with after the fact here. But one question we have here is, let's see, which one do I want to pick here? Is there a tactic? I think this comes from sort of that January and March deadlines, the crunch for EDPS data. Is there a tactic that you would recommend to prepare for that?
Yeah. The tactic in my mind is to do it on an ongoing basis and reconcile it monthly.
Now they're part of that 50% that maybe didn't have a plan, or have a plan in place but haven't initiated. Are there some things that they can do?
Well, if you're a provider, you can ask your plan to share that data with you. What does CMS have on either side of the house? Again, I would not have it be, driving toward a January or March sweep. I would have it a monthly. And whether you have a tool or not, as a provider, it's imperative that you communicate with your provider relations people or whoever at your plan to make sure that data is getting in, and ask them what they've done. What have they done, and how close is it from their perspective? And if you're a plan, make sure you're reconciling those 04s to your RAPs to see where the discrepancies are. Make sure that the errors you're getting on the front, the 02 errors, are resolved. Because if there's risk adjustable data in there, it's no longer additive, it is blended. And the worst scenario, if you don't have any of your EDPS in there matching your RAPs, you're going to have a 10% take back. And that's going to be pretty significant. So, and again, most people we've seen are trying to get that. We do have some plans that have been working diligently on this for a year now, since the mid-15, to get these in order.
Okay. Well, I'm afraid that's where we're going to have to leave it. Again, thank you, Pam, for walking us through this presentation, and thank you to the audience for participating in the poll questions, for your attention throughout. We will send follow-up with the questions we weren't able to get to today. And also, if you'd like to continue the discussion, as you exit the webinar, you will see one last question if you'd like to set up a meeting with someone at CO. Simply click yes to that, and we'll have one of our experts reach out to you so we can continue this conversation. And with that, we've reached the conclusion of today's conference. Thank you again, everyone, for your participation, and have a wonderful rest of your day.
Thanks, everyone.
Thank you.